In this video, we are going to cover flowcharts and tables from the topic of hypothyroidism. So, starting with table 1, causes of hypothyroidism. In the regions where iodine is commonly present in the food, the common cause of hypothyroidism is autoimmune thyroidism, like Hashimoto's thyroiditis or atrophic thyroiditis. And in the other regions where the iodine is not present in food, the common cause is iodine deficiency. The cause could be iatrogenic, like while treating the patient with hyperthyroidism. In this video, we are going to cover flowcharts and tables from the topic of hypothyroidism. So, starting with table 1, causes of hypothyroidism. In the regions of the world where iodine is present in the food, the common cause of hypothyroidism is autoimmune hypothyroidism, like Hashimoto's thyroiditis or atrophic thyroiditis. And in the other regions where iodine is not present, the common cause becomes iodine deficiency. The other cause could be iatrogenic, where there is overt treatment of hyperthyroidism, like over treatment of iodine 131 isotope of the thyroid gland, or subtotal or total thyroidectomy, external irradiation of neck for lymphoma or cancer, or it could be excess of the drugs like iodine. Here, when you give iodine in excess, it will have Wolf Chaikoff effect, and there temporarily the thyroid is suppressed, leading to hypothyroidism. And it could also be seen in iodine containing contrast media, and also while giving the drug amiodarone, because it contains one third of its weight contains iodine. Other drug includes lithium, antithyroid drugs like propylthiouracil, para-aminosalicylic acid, interferon alpha, and other cytokines, aminoglutathione, tyrosine kinase inhibitors like sunitinib, immune checkpoint inhibitors like ipilimumab, nivolumab, or pembrolizumab. In kids, the common cause is congenital hypothyroidism, the most common being dysharmonogenesis, and the other causes are absent or ectopic thyroid gland or TSH receptor mutation, or infiltrative disorders like amyloidosis, sarcoidosis, hemochromatosis, scleroderma, cystinosis, renal thyroiditis. And in patients with hemangioma, there is excess of release of type 3 deiodinase. And this type 3 deiodinase converts T4 and T3 into reverse T4 and reverse T3. And hence it inactivates both T3 and T4. And in this way, patients with infantile hemangioma also present with hypothyroidism. Then other causes could be transient, and these are inflammatory causes, because suppose if this is the thyroid gland and if there is any inflammatory attack on this thyroid gland, then initially there is release of the stored thyroid hormones from the thyroid gland, and in that it will act as thyrotoxicosis, and followed by there will be temporary suppression of this gland, and that will be acting as hypothyroidism. So, inflammatory disorders like silent thyroiditis or postpartum thyroiditis, it will have transient hypothyroidism. Other causes include subacute thyroiditis or withdrawal of supraphysiologic thyroxine treatment in individuals with intact thyroid gland. Because here the set point is changed, and that is why when you take out the drug, it will take some time for the gland to adjust for the new levels. Same is true for hyperthyroidism, which has been treated currently with I-131 treatment or subtotal thyroidectomy for Graves' disease. The causes could be secondary, like hypothyroidism, hypopituitarism, containing tumors, pituitary surgery or irradiation, infiltrative disorders, Sheehan syndrome, trauma, genetic forms like combined pituitary hormone deficiency. The most common cause for combined form is PROP1 gene defect. Or it could be isolated causes like TSH deficiency or inactivity. And this is the new addition in 22nd edition, drugs like bexarotene or mitotin. Or it could be because of hypothalamic disorders like tumors, trauma, infiltrative disorders, and Prader-Willi syndrome. This in this table, genetic causes of congenital hypothyroidism is given. From this table, if you want to remember something, try to remember this four genes. First of all, prop1 gene defect. This is the most common cause of combined pituitary hormone disorders. This will be a cause of central hypothyroidism, and here all the hormones will be decreased from the pituitary except ACTH. ACTH here will be normal. And if we talk about PIT1, this is also a cause of central hypothyroidism, and here also all the hormones will be decreased except FSH, LH, and ACTH. And in both of them, hypothyroidism will be seen. And if there is defect in GS alpha part of G cell receptor, then it will be known as Albright hereditary syndrome osteodystrophy. And here there will be resistance to TSH in that thyroid gland. And in Pendrin syndrome, there is defect of the ion channel, and this leads to Pendrit syndrome. And in this syndrome, specifically what is asked in the exam is there is sensory neural deafness because of loss of ion channel, and there is also hypothyroidism because of partial organification defect in the thyroid gland. Now let us come to signs and symptoms of hypothyroidism in order of descending frequency. So the symptoms include most common one, tiredness, weakness, followed by dry skin, feeling cold, hair loss, difficulty in concentrating and poor memory, constipation, weight gain, dyspnea, hoarse voice, menorrhagia, paresthesia, and impaired hearing. And out of all this, the most common one where students make mistake is menorrhagia. Then the common signs include dry and coarse skin, cool peripheral extremities, puffy face, hands and feet, that is myxedema, diffuse alopecia, bradycardia, peripheral edema, delayed tendon reflex, and this is also known as hung up reflex. And this is because of decrease in uptake of calcium from the sarcoplasmic reticulum. And patients could also have carpal tunnel syndrome and serous cavity effusion. And the type of effusion is exudative. These points are commonly asked in the Viva exam. Now coming to evaluation of patient with hypothyroidism. So in our OPD, we commonly do TSH and T4, free T4, and sometimes free T3 together. But in the Harrison flowchart, it is mentioned that first we should do TSH, and after TSH there are two arms. First, if TSH is normal, then if you are suspecting pituitary disorder, then you have to go for T4. And if you are not suspecting pituitary disorder, then no need to do any further test. And if you are suspecting, then do T4. And if T4 is normal, no need to do any further test. And if T4 is low, then you have to rule out other disorders like due to drug effect, or if the patient is sick, and in that state patient has sick euthyroid syndrome, and any further evaluation of pituitary function. Then in the other arm, suppose if TSH is elevated, it means that patient is having hypothyroidism, and then in that case we will do free T4. And suppose if free T4 is normal, it means that patient is just having mild hypothyroidism. And in those patients, we do anti-TPO, that is thyroid peroxidase antibodies. And if those patients are having this antibodies positive, or if the patient is symptomatic, in them we give T4 treatment, that is levothyroxine. And suppose if this antibody is negative, then we do annual follow up for the patient. So this could be asked that if antibodies are negative, then after how much duration the patient is followed up. So this is annual follow up. And suppose if T4 is also low, then the patient is having primary hypothyroidism. And in them also we again do anti-TPO antibodies. And suppose if antibodies are positive, then it is autoimmune hypothyroidism. And there also we treat the patient. And suppose if TPO antibody is negative, then we try to rule out other causes of hypothyroidism.